Good evening, everyone. Welcome. We're going to get started in just a couple of minutes. We've got a really big group with us this evening, and so we want to make sure that everyone has the opportunity to log on to Zoom. So thanks for being with us. Thanks for your patience. We'll get started in just a minute. If you're just joining, you're in the right spot. You found us. Thanks for being with us this evening. We've got a really big group, and so we want to make sure that everyone has the opportunity to join us via Zoom tonight. So we are going to get started in just about a minute or so. All right. Good evening, everyone. And thank you so much for joining our men's health webinar. We're so excited to have the opportunity to share important men's health education with this group tonight. My name is Brittany Conan, and I am the host of tonight's event. I'll start with a couple housekeeping items, and then I'll introduce our speaker. Most importantly, your participation is completely anonymous to other attendees. No one can see your face or your name, and any questions that you ask can only be seen by myself and the speaker. We do encourage interactive presentations. So if you'd like to ask a question, just type it in the chat box at the lower part of your screen, and then we'll save time at the end of the presentation to answer as many questions as we can. Tonight's webinar will be presented by Dr. Jeff Marotte, who is a prosthetic urologist and a men's health specialist at Arkansas Urology. Dr. Marotte, I know that your time is in very high demand, and I thank you for your willingness to be with us this evening to share this really important education with the group tonight. So with that, I'll go ahead and I'll turn it over to you.
Okay, well, I hope everyone can hear me and can see me okay. I'm here in Conway at Arkansas Urology, my office. And tonight we're going to go through the topics of erectile dysfunction and male stress urinary incontinence. And just want to thank everyone and thank Boston Scientific for allowing me to do this. I actually enjoy doing these webinars, sometimes in clinic where it's very hectic and there's time constraints. It's nice to kind of pause and go through these topics in a more casual manner, allow you to ask questions, allow you to digest it, and really learn more about it and learn more about the science of erectile dysfunction and stress incontinence. And, as a physician and as a surgeon, physician means teacher. And it's tonight I'll be enjoying teaching you more about erectile dysfunction and stress incontinence. So let's go on this journey together. I wanted to first talk about a web option that you can learn a lot about EDCure, and a lot of these slides will bring up questions that you may have and that you will be able to think about. And I would encourage you to go on to edcure.com, and it's a website that really helps you dive in and to learn about how to approach your partner about erectile dysfunction, to learn how to talk about this, because let's face it, this is sometimes a very uncomfortable topic to talk about, and we're not always equipped to learn how to talk about intimacy and sexual dysfunction and urinary incontinence with everybody. So I'd encourage you and your partner to go on this website and learn about erectile dysfunction and incontinence. It's a very good website, and I encourage you to learn more about it. So again, my name is Jeff Marotte. I'm a urologist. I've been practicing for over 20 years here in Conway. I'm with Arkansas Urology and joined them a little over 6 years ago. And, there's some of my credentials there. I specialize in not only men's health, but also prostate cancer, kidney cancer, and female reconstruction as well. So let's kind of dive into erectile dysfunction. So how do we define erectile dysfunction? Well, ED or erectile dysfunction is defined by the persistent inability to achieve or maintain an erection long enough to perform sexual intercourse. And a lot of times I just ask men bluntly, is your penis firm enough for penetration? And if you are able to penetrate, are you able to maintain that erection throughout intercourse? So this kind of slide here really emphasizes that if you have ED, you're not alone. Erectile dysfunction is very, very common. Matter of fact, 1 in 5 men, even over the age of 20, at some point in their life will suffer some erectile dysfunction. And then over the age of 40, about half of men are estimated to have the beginnings of erectile dysfunction. So it's very common. Let's talk about the science of erections. So with getting aroused, the nerves around the penis become activated and they cause the muscles inside the penile erectile tissue to become engorged with blood. And they have sort of the veins compressed so that blood stays in the penis until usually orgasm. It allows the penis to maintain erection. So if you can see my little arrow here, the penis is essentially made up of 3 different cylinders. You have 2 cylinders which cause erections. Those are called the corporal cavernosal bodies. And then you have the corporal spongiosum, which is the urethra. So again, inside these erectile tissues here, those are the sinusoids, which has the vessels and smooth muscle, which allows the erection to become firm. And at the base here, these veins sort of collapse to maintain the erection. So let's talk about the causes of erectile dysfunction. And here, so some of these things, this list of things here are things we can control and some things we can't control. Obviously, as you get older, erectile dysfunction becomes more common. But what is the alternative to getting older? We don't want to think about that. The other things we can somewhat control. So obviously smoking is a big cause for erectile dysfunction. And thankfully, cigarettes or cigarette smoking is going down, and I'm a big proponent in smoking cessation. These are obviously, if it's not good for your heart and your lungs, it's not going to be good for the erectile tissues of the penis. Diabetes is also a very large component of erectile dysfunction, which, in America, this is a very large problem, especially in the South. High blood pressure is also a big component. That's also very common. High cholesterol, that's also can be common, and that causes arteriosclerosis, and the arteries that lead blood flow to the penis can become narrowed, and you don't get great blood flow. And then there's other things like depression that also can cause erectile dysfunction, obesity, as well, and just maintaining a sedentary lifestyle. So again, there are things we can do to mitigate the risk for worsening erectile dysfunction, and we'll talk more about that. This graph here, again, kind of is a schematic which shows that diabetes is one of the major components of erectile dysfunction, vascular disease, and that includes high blood pressure, high cholesterol, those things, smoking, all those things can affect the blood vessels to the penis, which can cause ED. And as well, you have medications, a lot of medications that as we get older, our doctors, to treat some of these disease processes, we start these medicines. And although they can help high blood pressure, they can also have side effects sometimes with erectile dysfunction. And then we have other sort of minority causes here, endocrine disorders like low testosterone, neurological disorder if you've had some sort of spinal cord injury or brain trauma, and as well as pelvic surgery in the past. That's if you've had pelvic surgery such as rectal surgery or some other sort of pelvic surgery, we can injure the nerves or the blood vessels which supply the penis. So we also need to not discount that erectile dysfunction can really be a major cause for anxiety and depression in men. Obviously, anxiety and depression is also common, but having erectile dysfunction on top of that can also exacerbate it. And again, with low self-esteem and decreased quality of life, these are things that really go hand in hand with erectile dysfunction. And so, these are the reasons why I went into urology, is that these are things that we can treat and help men gain the self-confidence and become intimate again. So men with erectile dysfunction don't need to live with it. This is something that that Boston Scientific has been a leader in penile prostheses. And when we talk about doing a penile implant, we can be pretty confident to think that this is a highly satisfaction for men who have the implant as well as their partners. And if you ask men, the vast majority will say yes, I would do it again. So let's kind of dive into erectile dysfunction and diabetes. So half of men with diabetes will have sexual troubles caused by diabetes. And, that's erectile dysfunction. That can also be low testosterone. That can also be problems with orgasm and ejaculation. So, and we also know that, we've had Viagra and Cialis and all these other generics that have come out with these drugs for over 2-3 decades now. We know that men with diabetes, these medicines over time don't work as well. So when we look at, how really does diabetes affect the erectile tissues of the penis? If you kind of look at this diagram here, we see kind of good blood flow with the penile arteries coming down towards the erectile tissue. As you have diabetes, and if your diabetes is not well controlled and you have high blood sugars, that will over time cause this very small vessels that cause the erectile tissue to form to close up and collapse, and you don't get good blood flow. And over time, that can also cause sort of scarring and fibrosis of the corporal cavernosal bodies of the penis. And we know that even if you take the maximum dose of Viagra or Cialis or their generics, that if you don't have good blood flow, these pills are just really not going to work very well. So again, when we look at factors that may increase erectile dysfunction in men with diabetes, obviously, as you get older, your chance of diabetes is higher. We also want to know, well, how long have you had diabetes? Is it just been diagnosed? Which many times I'll diagnose men with diabetes here in the urology clinic. We'll see sugars in their urine. I'll get a blood test to show that their serum glucose levels are really high. And a lot of times I'll diagnose erectile dysfunction or diagnose diabetes just from them coming in talking about their erections. We also know that diabetes can cause vascular disease, and some of these diuretic treatments that we now use for diabetes that kind of dump the sugar into the urine, that can also have some effects with erections, as well as heart disease and diabetes go hand in hand. Let's talk about heart disease. So we know that there is a link between heart disease and erectile dysfunction. And what we are now know in the last 10 years or so is that a lot of times guys can present with erectile dysfunction even before they even know they know they have heart disease. And we'll kind of go through the next slide here to kind of show that the erections and are having poor erections is sort of the canary in the coal mine. They'll present often with erectile dysfunction in their 40s and 50s, and then later in their 60s, we find out that they have cardiovascular disease. So when you look at sort of the size of the arteries here, and you look at the penile artery, which again is fairly small, but you look at the same artery, which, the coronary arteries that supply the heart, these are almost the same size. And then you look at the ones that supply the brain or the leg, those are quite bigger compared to these blood vessels here. So if you can imagine, if you have high blood pressure, high cholesterol, diabetes, that's going to affect the smaller arteries often first. And again, we'll see this sometimes with erectile dysfunction before they actually have a heart attack or chest pain, or, in some horrible situations, even sudden cardiac death. So the good news is that we can reduce that risk. And so, I'm a big proponent when guys are coming in with erectile dysfunction who may not be eating well, they may be overweight, their BMI is high, they're not exercising, they're in a lot of stress, they may be smoking or drinking a little bit too excessively. These are things that we can reverse. And so, with men with erectile dysfunction, especially with early erectile dysfunction, I'm a big proponent in addressing these things first. And even men who have more advanced disease, obviously, these are things that are going to help you live longer, which I'm also a big proponent in. What about testosterone? So we know that low T occurs in men with low T occurs with man's body produces lower than normal testosterone levels. And as we get older, men's testosterone does sort of fall down, sort of like women's estrogen when they go through menopause. Men also go through sort of a menopause, you could say, and your testosterone levels sort of peak in your puberty and early 20s, and then by the 40 that starts to start slowly declining. And we also know that men who are obese, they have low testosterone levels. The high fat cells that you have in your body actually have an enzyme which converts testosterone to estrogen. And the more fat cells you have, the more your testosterone is going to be sort of shunted towards that estrogen. We also know that men who have diabetes that are poorly managed have a lot worse erections and low testosterone, as well as sleep apnea. If I encourage men, if they have a really, wide fat neck and they're having trouble buttoning their top button, that's a good sort of easy screening method to say that you might have sleep apnea. Sleep apnea does interfere the sleep cycles in the evening when you sleep. And, testosterone is released usually in the nighttime and it peaks at 4 a.m. and then it starts slowly declining. And so, if you have sleep apnea, that's going to interfere with that process of releasing that testosterone during the evening and when you sleep. As well as other chronic medical conditions, kidney dysfunction, cirrhosis of the liver, those things can also lower your testosterone. So men with low testosterone, they can have a sort of a variety of symptoms, which sometimes overlaps with other medical conditions. They have typically a low libido or low sex drive. I often ask men and their couples, well, how often do you think about sex? How often are you engaging in sexual activity? And that is sort of a good indicator, and that's important to discover during my evaluation. They can also have erectile dysfunction with the very low testosterone. And some of the other signs that we see, such as hot flashes, or if they're younger and they're still trying to have children, they can have a low sperm count and have difficulties with fertility. They also just are depressed. They have low motivation. They're not really excited about going to work out. Sometimes they have some difficulty concentrating and focusing clearly. And so those are the major symptoms of low T. And obviously, if men with erectile dysfunction who have these symptoms and erectile dysfunction, I'm going to be evaluating that too. And we treat low testosterone at Arkansas Urology, and there's different ways to get testosterone in your body. There are injections into the muscle, there's patches, there's creams, there's things you can squirt up your nose, there's now pills you can take. And so there's a wide variety to get testosterone replaced. And we follow that to make sure it's in the normal range. And if they have a normal, you get that testosterone in the normal range, then and they still have significant erectile dysfunction, then we need to delve in further to figure out why. Let's talk about prostate cancer and erectile dysfunction. So in my practice, obviously, I treat a lot of men with prostate cancer, and I perform radical prostatectomies radical prostatectomies using the Da Vinci, and been doing that since 2008. And you have two nerves which are kind of hugging the prostate, and a lot of times with appropriate patients, you can spare the nerves on both sides that can help maintain their erections. But vast majority of men who've had radical prostatectomy, especially in their older ages, they're competing against all the other problems that we just talked about. And then you add some possibility of some injury to the nerves or the stretching of the nerves and some changes in the blood flow during that surgery, which can make many men have significant erectile dysfunction after treatment. So let's kind of talk about what is a prostatectomy for the people on the video tonight that don't really know about specifically the surgery. So this is sort of a diagram showing the anatomy. This is the bladder here. You have to urinate through the prostate, through the urethra and out. The prostate's kind of like a donut, and you have to urinate through the donut hole. For prostate cancer, we remove the entire prostate, and then we connect the urethra here back down to the bladder here. And that's kind of the general schematic of what a prostatectomy is. So we know men with prostate cancer who have a radical prostatectomy, or they have radiation for their prostate, or they have cryotherapy for the prostate, that a significant amount of men, even though they had great erections before their treatment, many men, despite their best efforts of sparing the nerves or minimizing the radiation dose to the prostate and focusing just on the prostate, that they're going to have significant problems with erections down the road. And we know that men after radical prostatectomy, many men have significant ED after surgery. And in the younger population who had good erections before surgery, sometimes it can be up to a year before they kind of regain a functional erection. So that was prostate cancer. Let's talk about erectile dysfunction and its association with Peyronie's disease. So Peyronie's disease is basically a lump, a bump felt on the penis associated with typically curvature or a deformity of the erection. And sometimes it can be associated with pain. When I started in my residency program, back in the early 2000s, we really didn't have a whole lot of treatments for Peyronie's disease. There are some pills you can take that may affect and may decrease the curvature and decrease the plaque that is formed in the penis. And at that point in time, we used to think that Peyronie's was maybe 2% of the population at the most. But as I think this kind of correlated with the rapid growth in the medications for erectile dysfunction, the significant advertisement for erectile dysfunction. Men became more comfortable talking about their erections with their doctors. And now with the new treatments for Peyronie's disease, that we now know that it's probably more like 6% of the population of all men. At some point, usually men in their later 50s will develop Peyronie's disease. Not all men with Peyronie's disease have significant curvature, but we know that some men that is so significant that the curvature is so significant that they have difficulty penetrating. And also with Peyronie's, as it goes, sometimes it progresses with erectile dysfunction. Some of that plaque can cause such curvatures. It can decrease some of the blood flow. But also with men, as we know, as we talked about in the past slides, that this erectile dysfunction is common anyway, and this can sort of exacerbate it. So what are the treatment options for Peyronie's? There are some oral medicines that we can try. There's been a lot of studies that show that, some men that it helps, but it's not the majority. We also can do surgery to remove the plaque if they still have good erections. That surgery is not always successful. There are some side effects such as penile shortening with it. But it still can be a good option for men that still are maintaining good erections. They just need their curvature corrected. We also can do, and also there's injections for Peyronie's disease, which we do now. There's a new medication for that, which we inject sort of a collagen enzyme buster, which breaks up the abnormal collagen and can slowly sort of over time straighten out the penis. But for men who are pretty significantly severe, have significant severe Peyronie's disease, and their erectile dysfunction is worsening, then oftentimes a penile implant will be the best option for that man. So we can talk about, penile implant surgery with Peyronie's. During these procedures, I always do an erection test in the operating room before I do the implant to evaluate if there is curvature, so I can plan, what obstacles I may run into, and some techniques in the operating room that I can do to make sure that penis is as straight as it can be with the implant. Let's talk about the treatment options for ED. So, most of the time, your family physician or primary care provider will prescribe erectile dysfunction medications. And by the time they come see me, most men have been on these medications in the past, and either they're starting to lose their effect or they don't work at all. And so most urologists can treat advanced erectile dysfunction. And then there are some urologists who sort of specialize in what we call prosthetic urology, or doing these implants. So there's essentially kind of 4 different treatments. We obviously kind of want to start with pills typically. And, like I said, most family physicians will prescribe these first. I also sometimes will try to maximize the medications if they're not taken exactly appropriately, if they're timing it wrong, or the dose may be wrong, or we look at their other medications and is there a way we can maybe decrease some of the other medications that could be causing the erectile dysfunction, and that will help optimize the medicines. But when medicines fail, there are other things that we can go to. The next is a vacuum erection device. And essentially what we're doing is we're forcing blood flow through a vacuum pump into the penis, and then we trap the blood in the penis. And this is with a little ring that's sort of placed at the base of the penis here. It's sort of almost like a little rubber gasket of some sort. If that doesn't work, and some men find this sort of cumbersome, and they want to move on to other therapies, there's injection therapy. And I have hundreds of men in my practice who do injection therapy. It often works very well. And a lot of men, when you say you're going to have a needle be placed in the penis and you're going to do it, a lot of them get freaked out and say, no, I don't want to do that, stop, and the conversation's kind of over. But, I do say that this is a very small diabetic needle. It's a 25 gauge needle, very small. You inject it into that corporal body of the penis. That medicine transverses to both the corporal bodies. You inject on one side and it communicates with both of the corporal bodies. And within 10, 15 minutes, when you're aroused, you should get a firm enough erection for penetration. And then when injections fail, or they are just don't want to do that anymore, then we move towards the penile implant. So again, lifestyle changes, mental health support. We always want to typically start with the least invasive and then go towards the penile prosthesis. We talked about doing a healthy lifestyle of quitting smoking, losing weight, increasing physical activity to help prevent further worsening of the erectile dysfunction. So again, I'm a big proponent of doing all these things that we can maximize the erections and do things that are in our control. We also need to talk about the psychotherapy. Often couples need to have, an honest talk and to communicate. Sometimes with especially younger guys in their 40s who really have no physiologic reason that would account for erectile dysfunction, they can be either depressed, or they have anxiety, or they've had some sort of trauma in the past, that have some psychosexual disorder that sometimes we need to address so that they can get erections again. So let's talk about the oral medications. Again, these medicines have, revolutionized sexual function, often in men in America over the last 20, 25 years. They've helped millions of men, and these are very safe medications. Some of the side effects are the headache, the facial flushing. Sometimes you can get some sort of dyspepsia or upset reflux type symptoms. And then if you're also sometimes taking an alpha blocker, such as Flomax or those sort of the family of those prostate medicines to help men urinate better. There's sometimes that there's theoretically you could lower your blood pressure. And then certain men can't take these PD5 inhibitors if they're taking nitrates. Men would carry around the little brown bottle, and if they had chest pain, they would pop one of those little nitrates. So when you take those nitrates, you cannot be taking these medicines because of the risk of low blood pressure. Vacuum erection device, again, it does work for many men, and I have many men who like it. It works well, and but some of the problems with the vacuum erection device is that when you have this little ring at the base during ejaculation or orgasm, some men can have pain. They can also, because of the vacuum pump and the ring, they can sometimes have bruising, especially if they're on some blood thinners. And then when you have that ring in the base, sometimes there is some penile numbness because you're essentially kind of cutting off a little bit of the blood flow to the sensory nerves of the penis. And especially if you have peripheral neuropathy or diabetes, that can be a little more significant. Intracavernosal injections. One of the big risks is you inject too much, the erection doesn't go down. That's called priapism. And priapism most commonly is from iatrogenic, or actually men giving themselves erections. It doesn't go down. They have to go either reverse it with a different medicine, which makes the erection go down, or if it doesn't go down with that, they have to go to the emergency room, and then they call the urologist. Some of the most common reasons men sort of discontinue the corporal injections is that they just have a poor response. After a while, there may be some scarring and it just loses its effectiveness. There's also sort of the lack of spontaneity. Men have to pause, do the injection, wait a bit, and then they can have sex. And so it does, sometimes, I guess, lessen the mood, you could say, and some men just would rather be more spontaneous. Well, let's talk about the penile implant. So we're going to go through sort of the anatomy and how this is performed. The main thing I tell men is that, which just a lot of men don't know anything about it. They come in and they think it's something external they put on or something. No, this is all implanted in the body. No one can tell that you have it unless you tell them. I tell men you could go to the gym and take a shower and no one's going to be able to tell. It also has the benefit of being more spontaneous, and it can be maintained as long as the man desires. So some of the common side effects or complications, you can have postoperative genital pain or infection. This is a foreign body placed in your body, but I think Boston Scientific has done a great job in mitigating those risks, which I'll visit with in a moment. And this is a device. It has tubing, it has fluids. There's fluid moving in and out. So sometimes there could be mechanical malfunctions or failures. And then in some men, it can actually get too close to the skin and potentially erode through the skin or causing a pending erosion. And we're always being mindful of looking out for those sort of complications. But again, the vast majority of men who get penile prostheses, this does not happen, and that most would recommend their friend of having it done. So there are 3 different penile prostheses. There's the AMS 700, which is a great prosthesis. We've been implanting these for quite some time. Boston Scientific has done a great job constantly innovating with the prostheses. There is a kind of a low profile reservoir which is placed, which you won't feel inside your body. It's tucked behind the pubic bone. There's a newer Tenaccio pump, which has just come out, and this makes it a little bit easier to pump. And there's certain reason why we want to implant this. And then there's some men who would rather just have a firm penis that they can sort of malleable prosthesis, which they can bend down and then they can bend up. There's no fluid, there's no pump. It's just always in, and they can, some men, it works well for them this way. So let's kind of talk about the actual device itself. One of the benefits of the AMS prosthesis, or the Boston Scientific prosthesis, is that they've actually coated the prosthesis with inhibizone, which is a combination of different antibiotics embedded into the implant. And so this has greatly reduced the infection rates. It's also designed to sort of closely mimic a natural erection. And when you pump it up as much as you can, it's going to be very firm. And when it's deflated, it's going to be very flaccid. So this is a little video here I think we'll kind of go through. I'm going to speed this up just a bit. Let's go ahead and play this. So again, this is a video here. You're going to have 2 cylinders in the penis. The pump is down in the scrotum, separate from the testicles. You pump it up. It's going to put fluid from the reservoir into the prosthesis, give the full erection. And then there's a little button you feel, you push that, and it's going to reverse the fluid back into the reservoir. This is a little standard warning that, with any prosthesis, especially men with diabetes, spinal cord injuries, or skin infections, they may have an increased risk for infection, and it can result in some penile shortening occasionally. I think I always try to be frank and honest with men to kind of stretch out the penis in the clinic and say, this is the length of the prosthesis we're going to be giving you. Obviously, I will try to put the maximum size in that's appropriate for that patient. So what to expect from the procedure? So it's usually done on an outpatient basis. I do many of these prostheses at our surgery center in Little Rock. There are some times where being in the hospital may be appropriate, and we will do it there as well. But most men go home the same day, and depending on the incision or the type of depending on the anatomy of the patient, we can either make an incision above sort of the penis, and in other patients, I do a penoscrotal incision, which is kind of at the base of the penis on the scrotum. Obviously, the patient's asleep, they won't feel anything. In general, it takes around an hour, sometimes an hour and a half, depending. Sometimes it takes a little bit more, depending on their anatomy, if there's any other scarring or Peyronie's disease, which I have to address at the time of surgery. In general, men go home the same day. You have a kind of a wrap around the area. Most men go home without a catheter in the penis. Some guys, if they have prostate trouble, it's better just to leave the catheter overnight. We take it out the next day. Now, there is swelling and bruising, and I'm honest with men to say that I wouldn't be planning on doing any sort of traveling or lawn work or other sort of duties that may require some physical effort for at least a month. And it usually around 4 to 6 weeks, that's when we actually start pumping it up and using the prosthesis, and it's ready to go. Now, in general, IPPs, or the inflatable penile prostheses, are covered by most insurance companies. Medicare has a national policy for ED, so that the vast majority of men have really no significant problems besides their out-of-pocket expenses and co-pays and all the shenanigans go on with insurance companies, but vast majority it's covered. And I think there's also a good program, especially on this ED cure, they can help you with that coverage. And obviously at Arkansas Urology, we pre-certify and just, make sure it's covered so there's no surprises. So again, the intended benefits of the prosthesis, the vast majority of men appreciate it and would recommend it to a friend. There are, again, that 2 to 3, 5% that either it gets infected or there's a malfunction or there's pain or it wasn't what they intended. And they don't have a good result, but the vast majority do. It is typically affordable. Again, insurance companies typically do cover this. It's reliable. The Boston Scientific IPP has a layering inside, which really makes it durable. So it doesn't have like an aneurysm that's going to bulge out in 10 to 15 years. And it's designed to be permanent and last for a very long time. And again, you don't have to inject, you don't have to do the vacuum pump. You don't have to take a pill and wait and worry if it's going to work or not. So it allows you to be in the most natural state. So again, no surgery is 100%. This is medicine. Not all patients are candidates for penile prostheses. So again, the complications, once we put the penile prosthesis in, that's kind of the last straw. You're not going to have normal natural erections. Again, that tissue is that the cylinder basically occupies that erectile tissue. You can't have malfunctions or failure leading to additional modifications, such as a pump needs to be revised and pulled in a different place if there's scarring, or there's just a malfunction, we need to correct it. But these are correctable things, and sometimes we need to go in and revise, and there's some additional healing, but we can, vast majority of time, save the man from having it removed and never having sex again. There also could be some migration of the prosthesis in certain cases, which can lead because of scar tissue, or if they have diabetes, that can potentially cause erosion near the skin. And so we're always being mindful of looking for that in the future. And again, infection, which we'd have to remove the prosthesis. Sometimes we can salvage it and put in a prosthesis at the same time. Sometimes it's better for the patient to remove it, allow them heal, and try to come back at another day. So again, you're not alone. And I think if you go on this website, you can learn a lot more than what I'm just talking about tonight. You can also learn from patient testimonials, which can talk in regular, man-to-man, women-to-man language that can really help men and feel comfortable about pursuing this. And again, not everyone is a candidate. Again, you can have device malfunction, infection, migration, exposure, and pain. This can also go with the malleable penile prosthesis. Again, you can have penile shortening, curvature, scarring, infection, pain. So let's kind of shift gears to talking about incontinence. And most likely we're going to mostly talking about stress incontinence. I'd also encourage you to go to this website, fixincontinence.com. Very similar to the ED Cure website. They have patient testimonials. You can learn as much as you'd like about this. So let's talk about stress urinary incontinence. So what is stress urinary incontinence? Well, that's what happens when, with movement or activity, it puts pressure on the bladder, causing involuntary leakage of urine when you don't want to leak urine. And that's usually from coughing, laughing, sneezing, running, heavy lifting. Many, many men deal with stress incontinence, and many men are bothered by it. So again, let's talk about the anatomy here. You have your bladder, you have your prostate. Here you have your sphincter. And so the sphincter is basically allows you to hold on to the urine as you walk around day to day, it sort of is always on. And then when you want to void or empty your bladder kind of squeezes and this muscle voluntarily relaxes and you empty your bladder. So let's talk about the causes and the other comorbidities associated with stress urinary incontinence. The most common, which I deal with, is usually men who've had prostate cancer and they've had surgery for prostate cancer or they've had radiation for prostate cancer. And sometimes in which men who've had prostatectomies and the PSA starts rising, they need to get radiation after to the pelvic area with surgery and radiation. That really does a number on that sphincter and causes more stress incontinence. Not in all men, but a good portion of them. And then there's other sort of benign causes of stress urinary incontinence. Men who've had prostate surgery for a very large prostate, that can cause some injury to the nerves, to the sphincter, which can cause involuntary stress incontinence. There can be neurogenic problems like strokes or tumors, pelvic surgeries we discussed, like rectal surgery or rectal radiation, or they could have had urethral stricture surgery in the past, and then that can cause some damage to the sphincter itself as well. So we know that having stress incontinence is not a fun way to live. There can be depression, anxiety about it, fear of going out in public, the nuisance of wearing multiple pads a day, the worry of the odor of the pads and the urine, and it really can cause significant depression in these men. Let's talk about specifically prostate cancer and stress incontinence. So there's approximately 90,000 radical prostatectomies performed each year in the United States. And of those men, 9 to 16% can have fairly significant stress incontinence. Now, most men who've had a radical prostatectomy, maybe wear one pad a day. They may have a little bit of leakage if they're very, very active and they're, and they may get out of the truck the wrong way and they may leak a little bit of urine. That's not really what we're talking about. We're talking about men that are wearing 2, 3, up to 10 pads a day and really are wet. So again, when we talk about the prostatectomy, when we do a radical prostate, we remove the prostate here. We connect the bladder neck back to the urethra, which has that sphincter there. But again, that sphincter is right where we did our prostatectomy. When we connect that there, you don't have that prostate sort of almost holding the urine in, especially if it's a very large prostate. You now have to rely on that wisp of muscle there to maintain your continence. Let's talk about the options. So with most men who I have with, have radical prostatectomy, we start with sometimes behavioral changes such as, well, don't drink a 2-liter of Coke or don't drink 4 coffees in the morning. Let's limit the fluids, limit the caffeine, limit the specific fluids or foods that maybe kind of exacerbate the bladder. We also talk about kind of going on a more timed period so we don't let the bladder get too full so that when you're more active, you'll have more stress incontinence. We also do a lot of pelvic physical therapy, the Kegel exercises, and men who've had a radical prostatectomy, we talk about stopping their stream midstream. That is the muscle that we need to exercise, and it's just like lifting weights. The more you lift, the longer you lift, the stronger that muscle will be, and the less incontinence they will have. But unfortunately, besides behavioral changes and pelvic Kegel exercises, often men just cope with it. And it's actually kind of sad when I see men come in who've had stress incontinence. They've had a radical prostate maybe 10, 15 years ago, and they've been living with this severe incontinence for a long time and just coping with it. And so unfortunately, it's my job tonight is to educate men that there's procedures out there that we can do to help you. There's 2 main procedures which I do to help men with stress incontinence. One is for the mild and moderate incontinence, and one is typically for the more severe incontinence. So there is called a Advance XP male sling. And just like women who have stress incontinence after having babies, and those have been very popular for 2-3 decades, works very well. It basically is a piece of mesh which compresses the urethra and acts as a backboard, so that when they do lift or empty or strain or walk or run, they'll have a backboard to help that urine stay in the bladder. The same sort of design as with the male sling, and it's done a little bit differently, but it still is a relatively minimally invasive procedure to help men with the mild to moderate incontinence. And we've studied this for quite some time, that it does work, and that men who are appropriate candidates and selected appropriately, the vast majority of them will have improvement in their leakage. Well, how does it work? Again, it is a hammock which it's gone through the obturator foramen. It's an incision, about maybe 2 to 3 inches beneath the scrotum, between the scrotum and the rectum and the perineum. There's 2 other small little incisions which are up kind of near the pubic bone. And I place this sling here deep down towards the urethra, where that sphincter has that injury or the weakness, and I compress that bulbar urethra and lift up to provide that extra resistance that is needed in order to maintain continence. There also is an artificial urinary sphincter, and this has also been around for decades. They've also been through revisions, again, with the inhibisome, which is the antibiotic coating. And it's a great option for men who have significant incontinence. So it was designed to treat male stress incontinence following prostate surgery, and that's how it was originally designed. It also can treat, moderate incontinence too. It basically mimics the normal anatomic sphincter. It is basically a cuff which squeezes around the urethra to maintain your continence. And then when you want to empty your bladder, you squeeze the pump in the scrotum, it opens up, urine gravity allows the urine to pass, and then it automatically closes back up and you maintain your continence again. So again, this is sort of the anatomy here. You have a cuff which goes around the urethra, almost towards where that sphincter was or is. And that cuff is connected to a pump, which is connected to a reservoir here with the pressure balloon regulator, which has fluid in it, which again keeps pressure on that cuff all the time. And when you want to urinate, you squeeze the pump, it releases that cuff, urine passes, and then automatically closes back up. If you have a full bladder, you may have to keep squeezing it to completely empty your bladder. Here's a little video too. So we're going to kind of go through this. Speed this up. So again, here's the pump down in the scrotum. There's the cuff. There's the pressure regulated balloon. When you pump that up, urine passes through, and then the pressure balloon tells the cuff to close back up automatically. Again, just as we had with the penile prosthesis, you can have device malfunction, failure, leading additional surgery. In some cases, you can have that pressure erode through into the urethra. You can also have urinary retention, and that it's almost too tight, but we do things in the operating room to prevent that. And again, this is a foreign body we're putting into someone. So as with any hip or shoulder surgery or any implant, there can always be infection. And you can also have pain and soreness around that area. So what to expect from the procedure? Again, this is a relatively small incision in the perineum, again, between the scrotum and the rectum there. I put in the cuff, measure the size of the urethra, put the cuff in, put the pump in, tuck the reservoir behind the pubic bone. No one can tell that you have it, and allows you to, similar to around the penile prosthesis time frame, it takes around 4 to 6 weeks to let the swelling go down. We will activate the pump in the clinic and you're good to go. So again, as with you have with the penile prosthesis, men who have this, as you can imagine, going from completely incontinent, wearing diapers, to wearing maybe one pad for security, they're going to be very happy. And these are some of the happiest patients I've seen. So again, these are meant to be implanted and to last a very, very long time. The insurance coverage is typically also very good. I haven't seen any insurance companies deny it. But again, there's no guarantee depending on your insurance coverage. But again, vast majority of insurance companies cover this. So this is Herschel. It took me from 9 pads a day to 1. I wear 1 pad because I like to laugh, and it makes me feel like I can do things with confidence. I don't have to worry if I wet on myself. And so again, these are very, very happy patients, life-changing. So again, the intention for this is to achieve bladder control, being able to urinate when you want to. Everything's inside the body. No one can tell that you have it. And high patient satisfaction, and it kind of renews normalcy and renewed confidence. Potential risks: you can have device failure, urinary retention, postoperative pain, irritation at the wound site. These are things that typically can be remedied if we run into them. Again, you may have to have revisions. There's rare instances where you can have erosion of that cuff into the urethra, which would require us to need to remove it. This is slightly more common in men who've had prostate surgery followed by radiation. Radiation affects the tissues in the pelvis and the penis and the urethra. It causes it to atrophy a little bit. And when you have something chronically pressing on something that's already kind of atrophied, there's always a risk that it could erode through. So, and I take that into account with that history when implanting these devices. So in summary, when you talk about incontinence, it is a known side effect for prostate cancer treatments, as well as some other conditions. There's a variety of treatment options like the sling or the sphincter. Options can be uncomfortable, but curative. These devices are meant to be long-term. And you can speak to your urologist or me if you'd like to, and more about it. We talked about some of the, again, the complications of the sling, retention, pain, pelvic organ dysfunction, erosion. Same thing with the artificial sphincter. One thing that Boston Scientific has done, which I'm a big proponent of too, is that, you know, I can talk to you about this, and obviously tonight I can have a longer time period to do that. But in the rush of the clinic, it's always good to really talk to someone who's been through it. And they've done a good job at finding patients there's been thousands and thousands of men who've gone through this, and you get to match up with someone to visit with them, have a conversation with them. How did you go through it? How did you choose your doctor? Did you have any problems? You know, how has it changed your life? You know, personal questions that really are questions that you might have that you want answers to. What they'll do is they'll actually kind of match you up with someone who maybe have similar sort of life experiences as with you. Maybe you're both in the military. Maybe you both have diabetes and high blood pressure. Maybe you're both severely overweight, have similar hobbies. And so you can kind of relate to these men in a better way. So these are a lot of the references. And I think we're through with the slide deck. So now's the time where I enjoy, answering questions. And I think